Bienvenidos al quinto Congreso Mundial de Sexología Médica. Este congreso es patrocinado por
Hello everybody, I want to thank all the participants of the project of this international fully digital Congress of the World Association for Sexual Medicine and Sexology. This is a very important effort and I think it's a very interesting idea. I thank you again and I hope you like the presentation I will give. My presentation, my name is Saffon. I will present to you premature ejaculation, a general approach. I work for Boston Medical Group as the director for Colombia and Peru, and I also work as the director of the chapter of sexual health and reproductive therapy for the Federation of the OMLAT, which is the federation that takes in account all the low-intensity extracorporeal shockwave therapy treatments. First of all, to define premature ejaculation, we can say, as the ISSM definition, that it's defined as an ejaculation that occurs always or almost always before or within a minute after vaginal penetration, given by the inability to delay ejaculation with negative personal consequences such as anguish, discomfort, frustration, and or evasion of sexual intimacy. Here we have basically the same, but with more explicative points that we should remember. First of all is time. In my experience, time is not the most important part to take in account, but we should know that if a person says that ejaculation occurs always or nearly always prior or within about 1 minute of vaginal penetration, we should call it premature ejaculation. We should also take in account the inability to delay the ejaculation on nearly all the penetrations of the patient. It's also important to know, and for me this is the most important part, that is that this produces personal consequences such as distress, bother, frustration, and or avoidance of sexual intimacy. So if we have a patient that comes to our consultation and basically says that has a short time of intravaginal latency, and this is mixed with negative personal consequences, then mostly we can be in front of a patient that has premature ejaculation. Here we see the graph of the sexual response. This is the classical graph that we have always studied, that was proposed by Master and Johnson in 1966. Here it's very interesting that we can see in the right, or we can see how the difference between the two graphs is basically given by a short plateau phase. We have the excitement phase, the plateau phase, and the orgasmic phase, and if a person has a short plateau phase or has no plateau phase, then it's how we can graph the premature ejaculation sexual response patient. So basically what we tell our patients is that they have a very short or have no plateau, and they go from minimal excitation or erection to the maximal or rapid ejaculation or orgasm in the excitement phase. This means that the patient has premature ejaculation. How can we classify premature ejaculation? There are many classifications. I really like this one because it takes in account all the types of patients that comes to our medical consultation. So we have the two classic ones that are the first two that are lifelong and acquired. Lifelong is the patient that has always had premature ejaculation since his first sexual intercourse. Here we ask, or we think that the basis or the origin of this is more neurobiological disorder. There are many studies that show that there is a genetical relation here, and there is a familiar trans thing that we can pass from father to son, and people don't really know this, but with lifelong premature ejaculation, this is something that it's already known. There are many studies, and it's a main thing to take in account. So basically, patients with lifelong premature ejaculations are patients that have or refer premature ejaculation on all their sexual intercourses. It's not differed from one couple or another. It may change a little bit, but it's almost always having this problem. With the acquired premature ejaculation, we have the patient that says that has had a normal sexual life, and from one time on, he refers to start feeling the symptoms of premature ejaculation. So here we start to think about many other possibilities or basis of what can be happening here to our patient and what can be causing the premature ejaculation here. So with acquired premature ejaculation, first we can have patients that have premature ejaculation with some couples and don't have it with others. This means we have to differ if the premature ejaculation here is permanent or occurs always, or if it's situational. Next thing we have to take in account is what could be the factors that cause this premature ejaculation. So we have neurophysiological factors. This means we can have the patients or the typical patient that has extra sensitivity on the penis. In my experience, this is not the most important cause of premature ejaculation, acquired premature ejaculation, but we still have to take in account this. And another factor here is medical factors. It can be endocrine factors such as hyperthyroidism, or urological factors such as chronic prostate problems or infections, or we can have psychological factors, and here is where we can have the patients that have a situational type of acquired premature ejaculation. The next type of premature ejaculation is the natural premature ejaculation, which is a normal variation in sexual performance. So this basically is not a diagnostic or it cannot be catalogized as a dysfunction, but this is the patient that says that has changed recently of couple, or has almost no sexual intercourse, so has long time between each encounter. And this means that it's normal for a patient that doesn't have a frequency in sexual intercourse, or that has changed of couple, or that refers with a new couple, really high excitation. So this type of patients should be taken in account as a natural variant of premature ejaculation. This doesn't mean we are not going to help these patients. This means it will lead us to another or a different way of treating this type of patients. And like premature ejaculation is the patient that says or subjectively feels short time of ejaculation, but does not fit in the diagnosis, because typically these patients are patients that say they have 6 or 10 or more minutes of latency, intravaginal latency, but they feel it has gotten shorter than what they had before. So this means maybe before they felt they could stand 20 minutes, and now they don't feel well because they say they can stand only 10 minutes. So theoretically, this patient has no premature ejaculation, but they do feel bad about it, and they start feeling psychological problems with this. So these patients also need to be treated, also need help, but the way we treat them are different as lifelong or acquired patients. So we said basically that premature ejaculation has a genetic origin, or basically the lifelong one. So here we have one of the last studies that have showed that serotonin transporter promoter region, the 5-HTT-LPR, or the polymorphism in association with intravaginal ejaculation latency time in Dutch men with lifelong premature ejaculation. Basically what we saw here is that there is a correlation of a mutation that is associated with lifelong premature ejaculation. There are multiple studies that show a genetic association in lifelong premature ejaculation. However, we cannot say that performance and anxiety is no longer important or is not contributing in addition to this sexual dysfunction. What we can say is that more or less there is a relationship. About 26% of the patients with lifelong premature ejaculation have or can have a genetical association. What do we have? In nature, rapid ejaculation is the rule. So what this means is that maybe in our genes, the rapid ejaculation is what we have had during our evolution. Why? Because basically what we needed in our ancient lives was basically to transcend our genetic code. And the most efficient way to do this was basically to do it as fast as possible, to have the ejaculation as fast as possible, and to have the possibility to procreate as most couples as possible. So basically nature has the basis of fast ejaculation, and we are not an exception. The only thing is that this has been changing during our evolution, and right now sexual relationships has much more to do with personal and with the couple feeling and how they have the possibilities to disinvolve in a relation, and the part that is associated to procreation is not so important right now, or is not the main part only, because basically right now people have their sexual lives and they only think about procreation in one small part of their sexual life. So what we have here, we have some studies that show how premature ejaculation, the prevalence and attitudes. This is a survey, the PEPA survey. So what we can see here is that this changes a little bit between ages, and opposed as many people thought that this was basically a problem of young people. It's not. It's a problem of all, during all the ages, and people just say that suffer premature ejaculation during all their lives, basically. So starting from 18 to 24 years, that was 18% given, up to the 55 or to 64 years that show up with a 25% of premature ejaculation prevalence between the population. Here we have a study that was done in Buenos Aires in 2004, where we can see the prevalence and the impact of premature ejaculation in Latin America. So we can see basically that we have the same percentage. We have more or less a total 23% of prevalence or frequency of premature ejaculation between the men that were evaluated. We can see that there is also difference between some countries, going from 15% with Argentina up to 32% with Brazil, and it varies with Colombia, Mexico, and Venezuela. Here we have a very interesting study where we compare patients that had or said that had premature ejaculation and patients that did not have premature ejaculation. In red, we have the patients that said they did have premature ejaculation, and basically what we can see here is the time that they refer between the people that say they have premature ejaculation. So basically we have that all patients that, or the most quantity of patients that go from 0 to 2 minutes, the majority of people say, or men say, that they have premature ejaculation, even though there is a small group of men that have less than 1 minute of latency, and even though they say they don't have premature ejaculation, which is very interesting. And that's why I say that time is not the most important factor in the diagnosis of premature ejaculation. But yes, mostly the biggest quantity of men that get in the rank of premature ejaculation go between 0 and 2 minutes, and go up to 9 minutes. So here we have to take in account all the patients that have different types of diagnosis, or the different types I mentioned to you before of premature ejaculation that does not depend only on time. And we start seeing that patients that say that have a latency over 3.5 or 4 minutes have less chance to feel or to say they have premature ejaculation. So we can say that patients that last longer than 4 minutes have lower risk to feel they are having a problem of premature ejaculation. Why we can see this here is that the median of men without premature ejaculation was around 7.3 minutes, and the median with, or the patients that had premature ejaculation was around 1.8 minutes. Here we have another study that was very interesting, where we could see how in seconds the patients reported that have premature ejaculation within the time of latency or intravaginal latency. This study was made in Holland, Spain, and Turkey, and the UK. And what we could see here is that the median of time that, it's not the patients that had premature ejaculation, but it was a study done between normal men. It's a survey, a multinational survey of intravaginal latency time, where men without premature ejaculation said what was the time they had. And the median between all men, healthy men without premature ejaculation, was 5.4 minutes. Here we have a very important part of what we can see, or we see usually in our patients with premature ejaculation, is that this seriously affects the quality of life of our patients. This was a study, a very interesting study, that measured with a scale that went from 0 to 5, being 0 the most affected person or qualification, and 5 the less affected. We can see how patients with dark blue that had premature ejaculation in the United States had less control over ejaculation, and basically the same. We can see this in patients in the European Union, compared with patients that had non-premature ejaculation, that had more control. And this is a very representative scale. In personal distress, it's the same. We have the same difference all the time. We have, with premature ejaculation patients in the US and Europe, we can see how there is a very important difference in the scale, and patients with premature ejaculation qualify as much more distressed and affected compared to patients that referred no premature ejaculation. This also goes with satisfaction in sexual intercourse. It means that, as we may think and we see, patients that have premature ejaculation have less satisfaction. And the last one is very interesting also, because here we can see how interpersonal difficulty is really important in patients with premature ejaculation. And this, we can see it very frequently in our consultation of patients with premature ejaculation, because what we can see is that they come, and if they don't have a couple, it's very difficult for them to have a stable relation, because they feel scared of having to confront a couple with this problem and tell this person that they have this problem, and they feel a lot of shame of suffering this. So basically they cannot have a long relationship. And if they do have a relationship and the premature ejaculation is an acquired one, what happens is that usually we have that the couple starts attacking or asking the patient to change this, saying that there is insatisfaction during the intercourse, and this causes a lot of distress in the person that suffers premature ejaculation. So this is a very important thing to take in account, and there is a lot of patients that are ashamed on asking for help, and the biggest problem is that there is not many physicians that are disposed to give or to treat the patient with what this is required, because to treat premature ejaculation is something that takes a lot of time. This is a consultation that is not going to be solved over the first consultation. This will take a long time with the patient to help him confront this problem and to overpass it. So here we speak about the premature ejaculation treatment, where we can see how lifelong premature ejaculation is more about a neurobiological disorder, and we treat here, in my experience, the best way to treat patients here is taking in account pharmacotherapy combined with psychotherapy. Here, there are many studies that show better results with this combination with lifelong premature ejaculation, and also, in my experience, what I've seen is that in order to have good results here, there has to be a good communication or between the treatment or a multidisciplinary treatment with the patient. So here we can use the different type of pharmacotherapy that is available for patients, depending on how the patient is affected, on the time of latency. It's different to treat a patient that has premature ejaculation before the intercourse, or zero time of latency, than treating a patient that has maybe 2 minutes. Really, the difference here is important, and the patient that has extra or out of the vagina latency latency of ejaculation is really a patient that is more difficult to treat. With the acquired premature ejaculation, we have to take in account the causes. Here we have to see, we have to order tests or blood tests to this patient. We have to discard any endocrinological problem as hyperthyroidism. We also have to see if the patient has chronic prostate infections or illness. Maybe if there is chronic pain, this can also be associated with premature ejaculation, acquired premature ejaculation. And we also have to see if there is any other medical cause for the patient. We also have to see if there is a psychological cause. It's very common, or I've seen a lot in my consultation, patients that say that they had the problem once, and after that they started feeling anxiety before any relationship, and this may lead to a circle where the patient cannot regulate its or take control of his excitation because he's always feeling insecure when confronting or when going to have a sexual relationship. So these patients really need to have an evaluation of a basic evaluation of blood tests. Also need to have if there are any urinary symptoms, they need to have or to discard any prostatic illness or urinary tract infections. And after that, we need to take into account all the psychological problems of the patient. So here, pharmacotherapy and psychotherapy is very important. And if we find any other cause, we have to treat that or tell the patient to be referred or refer the patient to any other specialist depending on what we find. With the natural premature ejaculation, it's very important not to deny treatment to the patient. Here, what I usually do is I do counseling to my patients. I also recommend maybe at the beginning to lower down distress and anxiety before the relationship, maybe some lidocaine-based spray, and this really helps our patients. So here the message is, don't tell the patient, hey, you don't have premature ejaculation, go and have fun. Here, my message is, take seriously this with the patient and help him. Give him counseling and ask the patient to take in account some recommendations, and this will really make his life easier. This goes also with premature ejaculation, like the ones that say that they have used to have maybe 15 minutes and now they have 5. You have to take in account how if they have a couple, how she or he is feeling with this, because if the couple they have needs more time than what they have in the moment or what they can refer right now, then there is our problem. So we have to do a lot of counseling, we have to do a lot of sexual therapy, and the capability of helping these patients is really good. And if we don't help these patients, they will probably have problems for a long time and feel a very distressful life after this. So this is really important to take in account. Here we have a study that is really interesting of the patients that refer that with the anxiety they had about feeling they have premature ejaculation, they overdid a lot of treatments. So here is focusing what patients usually do before a consultation on the doctor is focusing on attention on other things, interrupting the stimulation, masturbating by themselves, special positions during sex, engaging in sex more often. Alcoholic beverages is a very continuous thing patients with premature ejaculation use to avoid premature ejaculation. Some have used the squeeze techniques, some have used creams or ointments, some use special condoms which have anesthetics, some use other recreational drugs, herbal or no prescriptional medication, and at the end, the list of treatments that patients refer is the prescription of medication and using a therapist or a psychosexual therapist. So this shows how the patient use a lot of methods, and the less they use are the ones that really help them, that are the last two ones. So we only have lower than 20% should say that they have used prescription medication or combined sexual therapies. So basically, for pharmacotherapy for premature ejaculation, we can use the dapagliflozin, 30 to 60 milligrams on demand. This only acts on serotonin. In my experience, this is a good medication, but it's not the best because having to use it on demand is not really very easy. Sometimes they don't have it, and this is a problem for the patient. Clomipramine is a very interesting medication. It's a very old medication also. The problem with clomipramine is that it comes in very high doses, and this really gives side effects to the patients. But what I have found in my consultation is that if I can give to my patient a lower dose, like a dose calculated by weight in the patient, more or less 2.5 to 5 milligrams daily, we can have very good results with low side effects. I have also experience with paroxetine, less experience with fluoxetine and sertraline. Paroxetine is also a good medication. Clomipramine, I have recommended to my patients to use it every other day or even every day, also the same with paroxetine. Topical anesthetics like based on lidocaine and prilocaine should always be recommended to use with condom to avoid the trespass of effect to the couple. And this can help, but this is not really a treatment for the patient. This is only something I use at the beginning of the therapy of my patients to lower the distress of my patients, or as an additional therapy when I see that maybe clomipramine or paroxetine is not enough. Psychosexual therapy, there is a lot of literature around this, but not many studies that say which one is the best to use. In my experience, what I recommend to my patients is cognitive behavioral changes or therapy, start and stop exercises, changes in sexual habits. It's very important with our patients to know their sexual habits, to see how they affront their relations, because a lot of times what I find in my patients is that they think that all that has to do with the sexual relationship is centered in the intercourse or the coitus. And if you take this with the patient and explain them that there are many other things that they can do to have pleasure and to give pleasure, this really changes the patient's life. So basically what I do is that I try to tell the patient first to acknowledge their own sexual excitement curve, to understand it, to know which things make them more aroused or less aroused, and starting from them, I give them keys that really help the patients to change their behavior and to have really good results. And the same thing I say to my patients, the best results are with combined therapy always. Here we have some experimental treatments. Neuromodulation is one thing that has come in the last years as a promising therapy for premature ejaculation. This is a non-invasive therapy that maybe with radio frequency or stimulation of the posterior tibial nerve. Results are not yet really solid. We are doing some investigation in my clinic about the posterior tibial nerve, and the results have been really promising. Next Congress, I promise to bring the results on this study, and what we have seen until now is that the results are quite good. The penial frenectomy and the penial neurotomy really have side effects, are not very secure, but there are some studies on the Midwest that say that could be good, but the risk is high, so I don't recommend these two. And to take home, I can say that we have to help our patient with life habits and sexual behavior. This should be really evaluated, taking in account, and help change this part of the life of our patient. This is the most important part of the treatment. After this, premature ejaculation requires a multidisciplinary approach. This is not a thing that we can just approach only by psychological treatment or by medical treatment. This is not the best way to approach, in my opinion, these patients. The best way is to give them a mixed therapy, a combined therapy, where we have psychosexual treatment and we also give medication and pharmacological treatment. Monotherapy is often insufficient and frustrating to our patients. We have to think on combined therapies. This is much better, gives better results, and also lowers side effects. Give lower doses of the medication is the best to have good results and good adherence to the treatment. Concomitant disease should be taken in account and treated if they exist. We have to take in account this. A lot of physicians forget that with patients that have acquired premature ejaculation, this is something to take in account. It's also important in sexual dysfunctions to understand that they drastically affect quality of life and self-esteem. So we really need to help these patients with the treatment and with the psychological overpassing of this. Sexual dysfunction usually have combined physical and psychological components. I truly think that we really need to understand more about premature ejaculation, and that there is a lot we can do from the physical and the psychological components of our patients' lives. Thank you very much. I hope you liked this presentation. If there are any questions, you can write to my mail, jsaffon@bostonmedical.com. Thank you very much. So I hope to see you on next congresses, and you can write me if there is any other question. So bye-bye.
Bienvenidos al quinto Congreso Mundial de Sexología Médica. Este congreso es patrocinado por